Okay.
Good morning, everybody. Thank you very much for joining us. This is our November session of the John Howard Society Speaker Series. I'm Liz. I live, work, and play on the unceded ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh people based in Vancouver. I am very pleased to be joined today by experts in the field of addictions and who are working in the opioid epidemic. Very pleased to be joined by David Browning, who is a GP, works on the downtown Eastside, as well as Joel Rustin and Jillyan MacNeil, who work with the community transition team in Nanaimo. So we'll be hearing from them consecutively. I think most people on this call would be very aware of the impact of the opioid epidemic throughout this year, as numbers of people who've died due to overdoses have continued to increase, and specifically in BC, there has been tragic numbers. So yeah, I know as well, of course, that COVID and the impact of the pandemic is an extra toll on everybody's mental health. So just inviting the teams here to speak to kind of what their experiences have been recently, how their teams have been managing and adapting. And of course, you're very welcome to submit questions on the right-hand side into the chat box. We'll have time at the end of the two presentations to respond to any questions you have. And we have myself here and Pinar, who are available if you need any technical assistance during the presentations. And with that, we will head over to David. So thanks very much, David. Over to you.
Thanks, Liz. Hello, everyone. My name is David Browning. I thought first to counteract my strange accent, I'd wear this little number with the Canadian flair. I'm also not wearing any formal pants, but you don't need to know any more about that. I'm a family physician. I'm living and working in Vancouver. Today, I'll talk a little bit about what I do in terms of addiction medicine in the downtown Eastside, as well as a couple other sites, and a little bit about addiction in general. I've been working in addiction medicine for 3 years now, and I have a background in psychiatry. Also work with patients with mental health conditions not related to substance use disorders. I do some general practice at a walk-in clinic, and I used to work on Disney Cruise Line as the ship's physician, but it's not really relevant now. So during the last 3 years, the landscape has been shifting quite rapidly in terms of addiction medicine, especially regarding the fentanyl crisis, as most of you are aware, and I will try to encapsulate some of that change and how it impacts my practice. In all of my dealings, I try to practice addiction medicine with a trauma-informed approach. This is definitely an evolving area of my practice and by no means a completed process. While a lot of my work involves managing withdrawal, prescribing medications, and forming a plan for the future, one of the most valuable things I think that I can offer to patients is to provide a safe and open space where they can feel heard. Because so often people with severe substance problems end up in busy emergency rooms or walk-in clinics, and they feel at least like a burden or at worst ignored and treated dismissively. And many patients actually sort of completely come to expect this, and when they are met with an open and sort of non-judgmental and curious approach, they can be quite shocked and suddenly be more open and sort of motivated to change. Some patients with less severe problems feel kind of overwhelmed with feelings of guilt when they're approaching a practitioner and shame. So this approach is equally important for them. There's, of course, no one-size-fits-all kind of method to such patients, and it's best to view each individual and to meet them at their current level. I try to view addiction as a kind of spectrum condition, with traumatic experiences really being the root of it all. While there are obviously other factors involved, there would seem to definitely be a strong correlation between the severity of the individual's addiction and the severity of their painful traumatic experiences. In this light, unless you're like an enlightened being like the Buddha, then we are all on the spectrum and dealing with our unresolved pain, the best that we can. So viewing addiction through this lens is helpful for our roles as helpers and caregivers, but also for our own journeys and experiences, because we can see what is similar instead of categorizing people as different or ill in a way that creates distance and further fosters isolation. As Gabor Mate famously says, the question is not why the addiction, but why the pain. So here are some of the clinics that I work in. CTCT is the Community Transitional Care Team. It is a facility that cares for complex patients that need to continue intravenous antibiotics who have been stepped down from the hospital. And they also have a comorbid addiction diagnosis. So these infections are usually related to IV drug use, infections like osteomyelitis or infective endocarditis and septic arthritis. These conditions often require months of intravenous antibiotic treatment, and patients will typically stay at our facility for a few weeks to a few months. There is 24-hour nursing care available. So on admission, I assess the needs of the patient and have a discussion about what we can provide at CTCT. We optimize their treatment plan, and then we'll be formulating a transition with their primary care providers for after discharge. So some patients use the opportunity to attempt to stop using illicit substances like particularly fentanyl and crystal meth, while others would rather we manage their withdrawal and their cravings and in an attempt to reduce their use. There are multiple tools and approaches that we can use, which I will mention briefly later. When I admit patients to CTCT, I gauge their readiness to decrease or to stop using and manage accordingly to where the patient is at, also encouraging harm reduction tactics where appropriate. Challenges with patients at CTCT can often involve the discharge planning and patients not having the needed support or community physicians with the necessary prescribing capabilities in the community. For example, we are more frequently using fentanyl patches in complex patients with severe opioid use disorder as well as chronic pain. So we manage to get the patients really well controlled, but then it can be a struggle to find them resources to continue this kind of approach in the community. So On-Site is another one of my clinics. On-Site is a withdrawal management center, and it's above Insight, which most people know about, the safe injection site. Patients are encouraged to consider discontinuing their use while they are at Insight. So when they are ready, they can then be transferred to On-Site, where they will stop using substances and they'll receive appropriate withdrawal management. At On-Site, it's mostly geared towards opiate and stimulant withdrawal, while Vancouver Detox is larger and has more capabilities and can manage alcohol withdrawal as well as other substances like GHB. Typically, the patients stay on our second floor at On-Site for about 1 to 2 weeks. And then they have been successfully managed from a withdrawal perspective. They are transferred to the third floor where they receive ongoing treatment as well as social work and planning possibly for a placement in a recovery house or other treatment centers. One of the biggest issues with On-Site might be considered the sort of revolving door phenomenon. I see the same patients often over and over, and they have been successfully withdrawn from substances, but then they return to the streets or to their previous life where they very quickly relapse if they haven't had some kind of ongoing care, right? And then they're back in my office in no time. Initially, I found this quite frustrating, but it has sort of forced me to relook at what might constitute success in this population. And if we are reducing the number of admissions, reducing the risk of overdose, and providing another chance at moving past the current situation, then there's certainly a win in a sort of harm reduction capacity. Patients I admitted On-Site are invariably severely intoxicated during the admission process because they've recently had their last hits before they come into the detox. This can, of course, make the admission process quite difficult, especially if they are agitated or excessively drowsy. But it can also provide an interesting sort of understanding into their psyche when some of their defenses are let down. Then I also work at 2 outpatient opiate agonist clinics. So this is for patients who require long-term treatment of opioid use disorder. We have a number of tools at our disposal to meet patients at their current level of need. The spectrum here can range from high-functioning professionals with a past opiate use disorder who need maintenance treatment to people who are homeless, who we engage with in a more sort of harm reduction capacity to reduce cravings and withdrawal, but who do not yet see themselves abstaining from fentanyl. Okay, so I thought I'd talk a little bit about the medications we use. Methadone, Cadian, and Suboxone are the drugs that I most frequently prescribe. Suboxone is a great medication if patients are planning to quit completely. Since it binds very tightly to the opioid receptors, it kind of displaces the other opioids like fentanyl. So if your opioid receptors are saturated with Suboxone, using fentanyl will have very little effect and you will get no sort of reinforcement. But this unfortunately also means that it can be very difficult to initiate Suboxone because it can kind of force the fentanyl out of your system and create what we call a precipitated withdrawal. And patients can become incredibly sick with that. So to overcome this, in the last year or so, we've introduced Suboxone microinductions, which are great to use on an outpatient basis as patients sort of take subtherapeutic doses and it gradually increases. And then they keep using their opioids, but then after about a week, they find that the fentanyl no longer gives them any effect. And so they sort of just naturally stop using. I won't go too much into the pharmacology or reasons for choosing one drug over another, but if you are interested, you're welcome to ask more about this at the end. And an extension of this principle has just recently been initiated, which is very promising. It's called Sublocade. And it's once initiated, the patients receive monthly injections that, again, saturate the receptors. And this sort of just once monthly approach is very efficient at preventing relapse and encouraging compliance. But again, here, patient selection is, of course, critical. There is also a lot of intravenous, or not a lot, but that's another option, is intravenous opioid agonist therapy, and that's available through a few clinics. I'm not involved in this at the moment, though, and it's very limited currently. So COVID has impacted my practice quite significantly. Obviously, I mostly now see patients remotely. There's also more leniency with prescribing rules, and we have initiated the safe drug supply, meaning that patients can get hydromorphone or dexedrine as harm reduction measures. This is because of the increasingly toxic supply of the drugs that has worsened since the borders have closed. An interesting use of this hydromorphone safe supply that I use is to help cover patients initiating methadone therapy, as this can be a very slow process, and methadone patients can take weeks to reach sort of satisfactory levels of opioid agonism. This means that they are woefully underdosed in the beginning and can experience sort of severe withdrawal and cravings until we reach a sufficient level of their methadone. So the hydromorphone really helps bridge this gap quite nicely in an outpatient setting, and hopefully guidelines for its use will be reviewed in the future. So overall, I view these harm reduction measures as a way of easing suffering and assisting these individuals with severe trauma until they may be ready or willing to really look at their pain and try to work through it. Of course, in some individuals, this is very unlikely to happen due to the severity of the trauma and the worlds that they live and function in, really. So we walk a fine line between idealism and pragmatism. But ultimately, as I previously alluded to, it's meeting every individual at their current situation, which is really important. So yeah, thank you everyone for listening. And my biggest take-home message would be, know that when you create a space for someone and you're fostering connection, you're making a truly meaningful difference. And that's something that can begin the healing. Thank you.
You did. That's such an important message. We appreciate you sharing that. And thanks for the presentation. If you have questions for David, like I mentioned, please submit them in the chat box on the right, and we'll get to them at the end of the session here. So now I will hand over to Joel and Jillian in Nanaimo. You guys able to switch your camera on?
Yes.
There you are. Hi. Thanks very much. I'll hand over to you.
Thanks. I'm going to speak first, and then I'm going to pass this on to Jillian. My name is Joel Rustin. I am the peer mentor on the NIMO's community transition team. I'm going to start off with a territorial acknowledgement. I just like to acknowledge that I work on the unceded territory of the Coast Salish people and on the traditional territory of the Sunamo people. And I'd also like to pledge to everybody that's watching today that I will use my voice. I will speak up the next time I hear somebody speaking ignorantly about First Nations in this country. I'm pledging that because I struggle with, And also, I believe, as much as I believe that territorial acknowledgements are important, I believe that they're used so often that I fear that they might go unnoticed sometimes, So I want to add this pledge in there. And I think also that working towards reconciliation can be an individual thing as part of a collective. So I believe it's going to start with me. So a little bit about myself. One of the things that qualified me for this role as a peer mentor is lived experience, which in my case is, over 20 years of active addiction, going back to when I was a kid, when I was a teenager, when I was in my 20s, when I was in my 30s. It wasn't until about 7 years ago that my life changed. I had a strong spiritual experience, followed by a spiritual awakening. Yeah, and since then, I guess maybe some people are not understanding me. Let's see here. I'm not sure about the connection. Hopefully, you all can hear me. But as I was saying, I went to university and finished my high school diploma. I got a 2-year diploma in social work, and also got some addiction studies as well. So today I want to talk about the community transition team in Toronto and across BC, and I'm going to tell you sort of what the program is, how it works, and some of the dynamics between social workers and peers and people. We talked a little bit about separate assessment teams, statistics in the past couple of years. I'm going to share some of my personal experience. So I'm going to start out with what is the transition? CCC, as we call it, is a CHSA program. So CHSA is Central Health Services Authority, it's a provincial health authority in BC. So the social worker in our program comes from PHSA. The peer mentors come from the NIMO's John Howard Society. In the NIMO's case, we are a substance use program meant to support people transitioning into community from corrections. We offer a variety of support in the area of release planning and outreach services. Upon release, we can help clients attend healthcare appointments, get medications, apply and transport to treatment, give information and access to community resources, counseling, social, housing, harm reduction, treatment goals, food banks, cultural, clothing, 12-step meetings, SMART meetings, pretty much anything you can think of that an outreach team does to support people in the community. We have probably done, and probably some things that you can't think of also that we have probably done for our clients over the last couple of years. We also act as a additional emotional support throughout the adjustment into the community. As well, we support family units as well as the individual, including supporting partners, parents, and children with their goals and their needs. Our program is voluntary and client-centered. It is inclusive of treatment and harm reduction approaches, and anything along that continuum. Whether the person is pre-contemplative and still using and has no no plans of stopping, or people that are in abstinence and in recovery. Our program has been around for about 2 years, a little bit over 2 years. And this program was created as a direct result from the opioid epidemic in British Columbia. So back in 2016 and 2017, there was a coroner's review panel that reviewed almost 2,000 deaths in BC. And out of those deaths, about 333, well, exactly 333, or 18%, were people who died while under community correction supervision or within 30 days of release from a correctional facility. So you can see there's a really high numbers with the direct correlation to corrections. 25% died within a year of release from BC corrections. And according to PHSA Dr. Sharifi, he says that people with opioid use disorder are as much as 12 times more likely to die of a drug overdose shortly after release from a correctional facility. This was from a peer review study published in 2016. So you can see that PHSA realized that there was all these people dying, getting released from BC corrections, and so they wanted to create some sort of a support network, some sort of a team that could help with this. So that's where the CTTs came from in BC. And just to give you some current stats, just a few months ago, in June of 2020, we recorded 177 deaths due to overdose. So that's almost 6 people dying every day in BC from overdose, which is a huge, sad, staggering number. So how does the community transition team work? How does the program work? Well, we meet people typically and ideally about 30 days before they're released from corrections. We meet them in the correctional facility. We meet them ideally also a few times in this 30 days, and we do some release planning, kind of talk about what do they want to do on the release day, what do they want to do on the first week, what do they want to do in the first 30 days, and ongoing, what are their long-term goals for the year. And I find that this is really the heart of the program. This was what separates us from a lot of other programs out there, is that we're able to meet our clients in the setting of corrections, and we're able to connect with them. And being a peer, for me, it's really sacred in a lot of ways, being able to make connections with people in this sort of controlled environment. So it really helps for rapport building trust with our clients, as opposed to meeting them on the streets or in a Tim Hortons or something like that. And in this environment, they are often also more vulnerable with us, I think, So yeah, it's a really, really cool part of our model. Release day is really important to us. Whenever we can, we support the clients on the release day, and that looks like for us is picking them up, meeting them at the gate from the correctional facility, taking them into the community, supporting them, taking them, where they need to go, which could be really a wide array of things. It could be directly to a treatment center. It could be to a recovery house. It could be just running errands, checking with probation, doing medical things. Sometimes it's just dropping them off with family or friends, or downtown even sometimes, whatever it is. We find that if we can get that piece in, that we're much more likely to have a good relationship with them ongoing. And after release day, we support them in the community for a certain amount of time, and that kind of depends really on the client. The ultimate goal for us is to transition them into not needing our support anymore. So that could look a couple different ways. That could be hooking up with other services, or it could be just kind of providing them with the tools that they need to care for themselves, basically. So that is sort of the CTT model in a nutshell, a quick summary of how our program works from beginning to end. We're primarily an outreach program, so we aim to spend about 80% of our time in the community and about 20% of our time in corrections. We are a client-centered, strength-based program. We are non-punitive, which is one of my favorite parts of the program. Why I really like working in this role is because our clients are never getting in trouble from us. We're never pointing our finger or waving our finger at them. It's just 100% support coming from us. The client has no obligation to work with us at any time, and they can disengage with us if they're ever ready to move on. Our referrals come from a few different places. Originally, it was mostly just from healthcare, which would be nurses, counselors, addiction counselors, mental health clinicians would sort of notice somebody and pass them on our way. Also, correctional officers, and more we're getting self-referrals from some of our posters and flyers that we have around the correctional facility, and also word of mouth, just from certain inmates or residents, as we call them, kind of telling other residents what kind of work we do. So those are nice referrals to get. And I want to talk a little bit about the dynamics of our team, and I know that one of the pioneers of this program that worked for PHSA, that unfortunately doesn't work for them anymore, but he used to tell us that he imagined us as being like Starsky and Hutch, like sort of out in the community, hitting the streets, making a difference, connecting with people. And I think I've really embraced that. I think our team has really embraced that philosophy, and also just, it's quite an amazing, like the CTT model is pretty amazing. I think just the way it's built with a social worker and a peer mentor, and me personally, like I've always felt really valued in this role, as well as Jillian, our other peer mentor that's just been hired about 6 months ago as a part-time additional support. So the three of us really have a cool energy, and it's a lot different than a lot of other public health teams out there in our community anyway, that don't have quite the same dynamic as us. So, and we also, we really support each other. We debrief each other. We kind of bounce things off each other. Myself and the social worker have really spent like literally hundreds and hundreds of hours discussing, kind of arguing things, building this program, over the last couple of years, and coming and overcoming obstacles. So it's been a pretty amazing experience. We are not the only CTT in BC. There's actually 5 CTTs. We were all created at the same time. There's one in Kamloops, there's one in Prince George, and there's 2 in the Vancouver area, and of course 1 here in Nanaimo. We have each kind of, although fundamentally we work on the same principles and the same model, we have each kind of evolved to work in our own communities, to work in our own correctional centers. We've also had a chance to support each other over the last couple of years. We've been meeting once a month on conference calls, which has been really amazing. I've actually had a chance to meet a couple of the other CTT members in person in Vancouver last year during a training, so that was pretty special. We've also all had a chance to work with each other over the last couple of years. We've referred clients to each other, which is pretty cool. We've done like what we call handoffs, where we kind of work as a relay team, transporting people to different parts of the province through the ferry system here, because we live in an island. And I know that some of the CTTs on the mainland have done the same kind of work, with kind of handing off clients and taking them where they want to go. So pretty cool, I think. Our program has really changed over the last couple of years. I mean, at least I can speak for the Nanaimo team. We've the social worker and I and our new social worker, or new peer mentor now, have really had to advocate for things that we believe in. Like, for example, this program was created for opioid clients exclusively, and we've expanded that through advocation to include people that are have other substance use issues, people that have mental health issues or just serious health issues even. So we've really worked really hard to fight for and change things that we believe in this program successfully. So that's also been another really cool part of this work. Some of the statistics over our first fiscal year, we had a total of 131 referrals. That's about 11 per month. 5 of those referrals were transferred to other CTTs upon release. So that's what I mean about like working with other CTTs and making referrals to them. 16 referrals, or about 20%, were not accepted by us because they were out of our geographical range. That means about 90 successful referrals were made to the Nanaimo CTT in our first year. That's about 8 per month. And out of those 90 successful referrals, 41 clients were seen in community. That's about 45%. About 29 of those 41 clients were seen on a continual basis beyond release date. So that gives you kind of an idea of the percentages of the people that we see sort of on an ongoing basis, and how many people sort of fall off from our program. Currently to date, we have had almost 200 referrals to our team in Nanaimo. So that's pretty exciting. Myself, as a peer mentor in this program over the last couple of years, I've had quite a lot of challenges, mainly, a lot of those challenges come from working with province-wide health authority, kind of dealing with the bureaucracy, especially in a lot of ways, and especially at the beginning, like feeling like an outsider, being a peer, being a John Howard employee, and working in a PHSA world has had a lot of interesting challenges on it, with it, being taken seriously. At the beginning, also had a lot of challenges with that, I think. I've had to really let a lot of things just kind of roll off me. Like, I take my work very seriously. I take this program very seriously. But if I took every little thing seriously, then I just would not have been successful in this role. So, I've kind of had to adapt in my own way. And I've also had, a lot of support from the social worker that I've been working with the last couple of years. I've had a lot of support from John Howard Society. Also from my supervisor at John Howard Society has been really great too. So, and as you can tell, like I've been really passionate about this program and about this work over the last couple of years. It's been a really amazing opportunity. Like I can't say enough about and I know the other CTTs as well. We've all kind of gone through changes and hiccups over the last couple of years, but it's just such an amazing group of people, peers and social workers, and yeah, like I said before, I really feel like my voice is valued in this role. So it's been really great in a lot of ways, and I just feel very grateful to have had this opportunity. And yeah, I thank everyone for listening. I was really excited to do this talk today. And I just want to close with talking just for a minute about mustaches. As many of you know, it's November. This is what some people call Movember. So if you see somebody walking around with a mustache that normally doesn't wear a mustache, I encourage you to go ask them about it and ask them why they're wearing it and who they're supporting. Maybe they lost somebody close to them to testicular cancer, or maybe suicide, or maybe somebody's having mental health issues. So yeah, I just wanted to put that little plug in here at the end. If you have no idea what I'm talking about right now, I encourage you to do some research on Movember and see what great things that's going on out there right now. So that's it for me. Jillyan MacNeil is going to be speaking next. She is our new peer mentor to our program. that's working part-time with us. So I'm just going to give it over to her now.
Hello, everybody. Just get that adjusted. Hi. So as Joel said, my name is Jillian. I'd just like to start with, I'd like to thank and acknowledge that I work and live on the unceded territory of the Coast Salish and on the traditional territory of the Snuneymuxw people. I'd also like to thank our veterans. Your sacrifice for our freedom will not be forgotten. So thank you to my fellow presenters, David and Joel. So my name is Jillian, and for my part in this, I'd like to personalize the overdose epidemic by sharing my story with all of you, talk a little bit about harm reduction and why it's important for me. So please bear with me, as I have never shared this much with so many people that I don't know, but I believe in the power of personal experience and being vulnerable. So I spent my youth in addiction. I remember the first time I used my DOC, and it was an instant connection to destruction and to the start of a long road through pain and suffering. The memory I would like to share is one part of my story, but I feel a significant one that explains my draw to harm reduction and client-centered approaches. After my addiction had started to change my life as a youth, my parents tried everything they possibly could to keep me safe, and that eventually led to a child protection order called a PCHAD in Alberta, which essentially placed a warrant for my arrest and then transported me to safe houses and involuntary detox. During one of my various arrests, it became violent and I was tackled and held down by an officer to the point of where I couldn't catch my breath. I'm not placing blame to anyone here, as I wasn't the ideal arrestee. So during this exchange we had afterwards, as I was quite ticked off about the whole experience, he used the phrase, "It doesn't matter what you say. Nobody will believe you because you're just an addict." Whew. As you can imagine, this affected me so deeply, and for the rest of my addiction, I believed him. This was always in the back of my mind when I spoke with anybody who I interacted with on a professional level. This one phrase kept me silent and kept me in secrecy about my addiction. So this played out with every counselor, mental health professional, and anybody who tried to help me in my life. I refused to talk to anybody about my addiction because I felt that they would judge me negatively. I felt that if I opened up about the things that I was experiencing, then I would be viewed in a different way, and that I would be viewed as bad. Through this secrecy, I never learned how to safely use drugs because I would never admit that I even used them, even though it was pretty clear that I was in active use. For the most part, I was a stimulant user, and I never knew my limit with any substance. I didn't know how my body would handle different doses of different substances. So that led to my first use of an opiate, and that also led to my first overdose. Luckily, I wasn't using alone when this happened, and the person that I was with was able to call for medical assistance, and I received CPR that saved my life. Back then, the drug supply wasn't toxic, and there was no need for naloxone, but I am always grateful for my experience and the future that I have today. I was referred to an addictions counselor the next day, and I was still prepared, after an overdose, to not disclose my addiction to this new counselor, until she started the conversation with how she overcame addiction herself and her personal journey in recovery. I felt this rush to relate to her. I opened up about my life like I never had before, and I finally shared my pain with somebody. It felt like a 900-pound weight had come off my chest. I felt like I was being understood for the first time ever. This wasn't when I entered sobriety, but this was the moment I started my own recovery, my personal red road. I started listening to somebody tell me safe ways to use and safe ways to protect myself in an addiction-led lifestyle, things that I could do every day to ensure that I wouldn't be in danger physically and would reduce my risk of another overdose. This experience is why I believe so strongly in a peer system and in open discussions about harm reduction, as this has inspired me to hopefully use my story to help others. I've been living in sobriety for 9 years, and I've used that time to heal myself with the ultimate goal of helping others. And as we all know, you can't help anybody else unless you help yourself first. So 5 years into sobriety, I took a leap and I signed up for a 1-year course at UNBC in Prince George for mental health and addictions, which led me on an educational journey where I could further explore this world in terms of employment, but also gave me the professional skills I needed to make the difference that I wanted. I was offered a job through this course at the Prince George Activator Society, where I worked for the past 4 years as an enhanced supervision worker for high-risk federal male offenders who are transitioning back into the community. It gave me the opportunity to use my skills that I had learned, but through this position, I wasn't free to tell my story due to the professional boundaries in place. So I've been working for the John Howard Society in Nanaimo as a part-time peer mentor for the community transition team and part-time at the Guthrie Therapeutic Community for 6 months now, and I am finally able to use my story to help others. I finally feel like I get to make the difference I've always wanted. With CTT, I am able to walk through situations with our clients with compassion, empathy, and relatable experience to bring them hope and inspiration as I was once given. We are able to discuss community connections such as 12-step programs, smart recovery, and Wellbriety on a personal level, as I act mostly as a coaching mentor, assisting in attainable goal setting and action planning in a non-clinical environment. The community transition team comes from a client-centered model where we are there to support any of the struggles a client is going through on their level, meeting their specific needs with no judgment and full acceptance, essentially meeting people where they're at. This includes harm reduction, which is a passion of mine. Harm reduction for the community transition team means assisting clients to OAT appointments, connecting clients to OAT clinics, connecting the clients to primary care facilitators, transporting clients to much needed medical appointments, transporting clients to counseling and appointments, and connecting clients to counseling offered in their hometown. Connecting and transporting clients to detox and treatment centers, providing naloxone training and kits for our clients, assisting clients with the knowledge we have gained about overdoses and safe supply, and finally just being there as emotional support when they need it. As a peer, I get to have these meaningful conversations about the harm reduction I use in my own life. As every person's journey through substance abuse and recovery is different, so are their views of harm reduction. Everywhere from complete abstinence to using prescribed medications for safety. Humanistic, client-centered, non-judgmental practice are things that make me proud to say as a John Howard team member. These are some personal core beliefs, and it is a wonderful experience to be able to say these things in my workplace and with the amazing people that I work with. Working with my fellow CTT peer Joel is constantly a reminder of how people can overcome and thrive through recovery. No life is disposable because of addiction, and we're living proof. I believe peer mentorship has a special place in all programs, and the passion from lived experience is an asset to our clients, coworkers, and employers. I just want to say thank you for taking the time to hear me out today. I really appreciate it.
So much, Jillian. Oh, please stay on the camera if you're feeling up to it. There you are. Thank you. Yeah, I think Patricia says it very poignantly. Thank you very much for being so brave. And yeah, what an honor to hear your story. Thank you.
Thank you very much.
Yeah. David, are you still there?
Yeah, I'm still here.
What?
Thank you, Jillian, for that really powerful message. It's so important that
Yeah.
people share their stories, and it really makes such a huge difference.
Thanks, guys.
I think I heard similar language from both of you about the value of seeing each person for their strengths and their merits and treating them individually, and also the risk of language that we, that often is said without fully understanding the impact on people, long-term impact. So we had a couple of questions come up. Somebody, Jackie asked, This was directed at Joel, but Joel or Jillian, maybe you could respond. Have you noticed a trend of how long a person normally works with you? I think she means kind of engages with the CTT team. Is it 3 months? Is it 6 months? Is it longer?
Yeah, I would say it's definitely case by case. When this program first started, we were meant to work with people for just 30 days post-release. So that's one of the things that we were kind of fighting for, working with people longer. So it's hard to say an average. We've had a couple of clients actually that we've worked with longer than a year. We have a couple that have just graduated recently actually from our program after a year that are in quite a bit better spot than they were. Yeah, but most times it's not quite that long. It's anywhere probably from 1 to a few months. Yeah, kind of a tough question to ask, but to answer, but it's case by case. Yeah.
Mm-hmm. Maybe we could ask the same question to David. Do you have a similar experience that it varies how long someone engages with the different services that you work with?
Yeah, it very much depends on the service. At on-site, patients will just stay for a week or two while we're managing their withdrawal. And of course, that's woefully insufficient in a long-term plan. So that's why on the third floor, we try and develop like a treatment center plan or something going forward. At CTCT, it depends on their infection, right? So how long they need their IV antibiotics for. So that can be anywhere from a few weeks to a couple months that we engage with them there. And then on my patients that I see at the private opiate clinics, it's an ongoing thing. So I see them for years.
Mm-hmm. Thank you. So our next question is from Nada, who asks, and we could ask this to both groups as well. Have you come up against safety issues such as gang involvement or weapons? Has that been a challenge in either of your work?
So for me, I think it's probably maybe more of an issue with Joel. Most of the patients I see have been already screened, and there are no weapons allowed, obviously, at on-site. I have been sort of physically assaulted once, but I've never had anything like weapons or gang involvement that have impacted me personally.
Thanks, David. Joel or Jillian?
Yeah, I mean, it hasn't been much of an issue for us. I mean, but just for the clientele we work with, we have a lot of things set in place, and there's assessments, and we often kind of get alerts if they have violence against, especially against social services workers. We find that most of our clients are really respectful. They kind of understand what we're doing. They know we're on their side. We haven't had any specific incidents so far, luckily, that at least that I've felt like I'm really, really in danger. But we have a lot of accountability. Like, people know where we are when we're out in the community. We do check-ins. So people kind of know what's going on. We pretty much always work at least two together. So there's not many situations where one of us will be one-on-one with the client, and we're constantly assessing situations, especially in the community, our environment. If we have a bad feeling, if we have a gut feeling, if we think something's wrong, we're always kind of just aware and to make sure that we're safe.
Thank you. Question here, I think it's directed at David. So I think, as I read it, I think it refers to individuals who are unable to access opioid agonist treatment in prison or correctional center, because not all prisons are able to support that. So do you have any experience in supporting individuals who might be in this position, who maybe want to access opioid agonist treatment but or therapy, but aren't able to because of a restriction about the place that they're currently either incarcerated or residing?
Right. So, I mean, I was wondering what the intention, if they meant prison or just in general that opiate agonist therapy isn't available. And it's true that it would be ideal if people could access this through their family doctors and through walk-in clinics as well. It's very much a case-by-case basis. Some physicians have their sort of methadone license. But yeah, when patients are incarcerated, it can be very, very challenging. So and again, I think you mentioned it before that the risk of overdose when they leave is so huge. A lot of patients do get treatment in prison, as far as I know. I'm not involved with that specifically, but yeah, I'm not talking about the correction facilities. I don't know much more than that.
Mm-hmm. Sorry, I think I don't know if you saw the last message. Della had confirmed she meant treatment centers, not in corrections. So.
Oh, right. So that's very interesting. That I've worked at some privatized treatment centers where they have this kind of mantra that people should just not use any kind of medication because it's not helping solve the problem, which can definitely be counterproductive in the long term. So often they sort of have a specific issue with methadone, but don't seem to be as concerned about other medications. But I think it's important that we use the tools that we have available, right? And that education is ongoing, and that patients' best opportunities are to. But that's also, I mean, in some cases there is an argument for that patients go into, say, a 6-month treatment and they stop like completely, or they withdrawn very quickly. And if they're in that supportive environment for another 6 months and they're getting extensive counseling and extensive programs, then that is one way of going about completely changing the life of the individual. Of course, it comes with its own set of risk factors. But I do think that agonist therapy should be available, especially if patients want it.
Mm-hmm. Thank you. Are there any more questions from anyone who's been able to listen in and watch the presentations today? And Joel and Jillian and David, do you guys have any questions for each other?
Mm-hmm.
Nothing.
No.
Thanks so much for both of you for the great work that you are doing. It's really inspiring to see there's people out there that are caring and working for this.
Thank you, David.
Thanks.
Thank you.
Thanks.
Yeah. One comment I believe we saw earlier from Angela. I think she said, directed to Joel and Jillian, thank you so much for your courage and your authentic heart. Yeah. So much appreciation to everybody for your presentation today. And the session has been recorded. In a couple of days, we'll be putting it up onto our blog on our website, so you can share it with anyone else who you think might be interested in the topic, and for anyone else who wasn't able to attend today. Oh, Kaylee's just coming through with a quick question. We'll wait just one more minute for that. It's a question about funding for the peer support program. Where do you get your funding from?
That's a good question. I don't have the perfect answer. I know it's PHSA funded, the Provincial Health Services, and I believe it's connected somehow to opioid agonist therapy. So it's some kind of funding coming from to help the opioid epidemic. Yeah.
Thank you.
You might know better than me, Liz.
You're absolutely right. Yep, it comes from the it's I guess the government priority to address the opioid risk of people overdosing as they leave prison. So yes, Joel said exactly right. And in BC, it's not the same across Canada, but in BC, the health services are now delivered by the Ministry of Health. by Provincial Health Services Authority, which is a relatively new shift. It previously was the Ministry of Justice who delivered health services to people in prison. So it's been a shift, and the CTT teams are one of the shifts that PHSA brought into the new provision in correctional health. Okay, I think that wraps up all of our questions. Okay, we're already up there with the recording on the blog, which is great. Pinar just posted that. And we'll send it out to everyone who attended and to our regular mailing list too. And we will certainly send it out to the presenters. So thank you so much for your time and all of your stories and journeys.
Thank you.
Thanks, everybody.
Have a
Thanks.
great day, everyone.
You too.
Bye.